بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. Today in this video we are going to talk about the acute lymphoblastic leukemia. First of all, we need to understand the definition of leukemia in general. Leukemia can be defined as a type of cancer of blood or bone marrow characterized by an abnormal increase of immature white blood cells called the blasts. Leukemia can be classified according to duration into acute and chronic, which last for more than 6 months. In this video, we are going to talk in details about the acute lymphoblastic leukemia. Acute lymphoblastic leukemia, aka ALL, is a malignant disease of bone marrow in which early lymphoid precursors proliferate and replace the normal hematopoietic cells. It is the most common leukemia in children. It accounts for 30% of all childhood cancers. 60% of all ALL patients are younger than 20 years old, and adult patients account for only 20%. The acute lymphoblastic leukemia is more prevalent in males than females. Acute lymphoblastic leukemia can be further classified using two different systems. First, the French-American-British system, which is based largely on morphology with little prognostic or therapeutic information to help guide treatment decisions. And second, the WHO system, which was revised in 2008 and discarded the FAB term since morphological classification has no role in clinical prognostic prevalence. It changed the classification to reflect increased understanding of the biology and molecular pathogenesis of the disease. FAB classification is subdivided into three types. First, L1, where the lymphocytes are small and rounded, with clumped chromatin. Second, we have the L2, where the lymphocytes are large and polymorphic, with clefted nuclei and fine chromatid. And finally, the L3, with large blasts with presence of nuclei and vacuolated cytoplasm. WHO classification. WHO classification uses the immunophenotyping technique. It divides the acute lymphoblastic leukemia into two major categories: precursor lymphoid neoplasm and mature lymphoid neoplasm. The precursor lymphoid neoplasms include both B lymphoblastic leukemia and T lymphoblastic leukemia. The new classification further subdivides the precursor B-cell acute lymphoblastic leukemia cases by molecular cytogenic abnormalities to provide prognostic and therapeutic information and to facilitate the implementation of specific molecularly targeted therapies. Burkitt's lymphoma is one of the subset of the acute lymphoblastic leukemia that is classified as mature B lymphoid neoplasm. Finally, the biphenotypic acute leukemia, which is rare and account only for 2 to 5% of the cases. After we finished the classification of acute lymphoblastic leukemia, now it's time to talk about the pathogenesis. The malignant cells of acute lymphoblastic leukemia are lymphoid precursor cells that are arrested in an early stage of development. This arrest is caused by an abnormal expression of genes, often as a result of chromosomal translocations. The lymphoblasts replace the normal marrow elements, resulting in a marked decrease of production of normal blood cells manifested as bone marrow failure. Consequently, anemia, thrombocytopenia, and neutropenia occur. The lymphoblasts also proliferate in other organs, particularly the liver, spleen, and lymph nodes, causing organomegaly.
After finishing the pathogenesis, now we'll talk about the clinical feature and how can we diagnose acute lymphoblastic leukemia. We'll start by the clinical presentation. The typical onset of clinical symptoms of acute lymphoblastic leukemia is rapid. The initial symptoms are not specific to acute lymphoblastic leukemia. They result from the lack of normal and healthy blood cells. The symptoms which appear are secondary to bone marrow failure or leukemic infiltration of extramedullary site. Symptoms which are related to bone marrow failure are pallor, fatigue, leathery, dizziness, and dyspnea reflecting the severity of anemia, fever and infection due to neutropenia, and hemorrhage manifestation like bruising, barbara, and bleeding as a result of thrombocytopenia. And the symptoms which are related to leukemic blast infiltration are bone pain and tenderness due to marrow expansion by leukemic blast, hepatomegaly and splenomegaly or lymphadenopathy at diagnosis, mediastinal masses which are seen on chest X-ray or CT scan occurring primarily in T acute lymphoblastic leukemia. Finally, meningeal syndrome sometimes which characterized by headache, nausea, vomiting, blurring of vision. Diagnosis is made by clinical feature and demonstration of blast in peripheral blood or bone marrow. The minimal blast percent required to diagnose acute leukemia is 20% or more blast in bone marrow aspirate. Once blasts are detected and found in the bone marrow, lineage must be established, either it was myeloid or lymphoid or undifferentiated cells. Traditionally, blast lineage has been established by cell morphology and cytochemical staining to MPO, which indicate if positive myeloid, or TDT, which indicate lymphoid in 95%. We do immunotyping using flow cytometry to determine blast surface antigen and improve diagnostic accuracy and the ability to distinguish between the lineage subtypes. Cytogenetics must be obtained to help diagnosis of genetics subtypes of acute lymphoblastic leukemia and to aid in predicting prognosis. Regarding to the laboratory diagnosis, blood tests may reveal too many white blood cells. The hallmark of acute leukemia is combination of pancytopenia with circulating blasts. Taking a bone marrow biopsy, the marrow is hypercellular with replacement of normal elements by leukemic blast cells in varying degrees. Presence of more than 20% of blasts are required for diagnosis of acute leukemia. Also, imaging tests such as X-ray, CT scan, and ultrasound may help to determine whether the cancer has spread to the brain or spinal cord or other parts of the body. Spinal fluid tests may be used to see whether the cancer has spread to the spinal fluid. Differential diagnoses include acute myeloid leukemia, aplastic anemia because it shares with the acute lymphoblastic leukemia, pancytopenia. More infiltration by the malignancies such as neuroblastoma and severe kinds of lymphoma. And finally, we will talk about the treatment and prognosis of acute lymphoblastic leukemia. We can classify the treatment into two categories, general treatment and specific treatment. In general treatment, we treat the symptoms, so we give blood transfusion in case of anemia, platelet transfusion in case of thrombocytopenia, and antibiotics to treat the infection. Sometimes we give antiemetics drugs to prevent the vomiting. Specific treatment include cytotoxic drugs, radiotherapy, and stem cell transplantation. We'll talk about them in details in the next few slides. The aim of treatment is to destroy the leukemic clone of cells without destroying the residual normal stem cells. The treatment for acute lymphoblastic leukemia falls into three separate phases. Induction phase, and in this phase, bulk of tumor is destroyed by combination chemotherapy. The patient goes to periods of marrow hypoplasia requiring intensive supportive therapy. Second, the consolidation phase. If remission has been achieved by induction therapy, residual disease is attacked by therapy during this phase. This consists of number of courses of chemotherapy. And last, maintenance phase, when bulk of a tumor is reduced to a minimum. Maintenance therapy is given in acute lymphoblastic leukemia for a period of about 2 to 3 years, and in this phase is not required for acute myeloblastic leukemia. In this diagram, you can see each drugs which required during every phase. Depending on your situation, the phases of treatment for acute lymphoblastic leukemia can span to 2 to 3. Prognostic factors in acute lymphoblastic leukemia. It might be favorable or unfavorable. If your patient came with low WBC count, his age was from 2 years to 10 years, female, white, no hepatosplenomegaly, no testicular enlargement, no CNS involvement, L1 type, time to clear blast from blood was less than 1 week and time to remission was less than 4 weeks, his chance to get better will be greater, unlike unfavorable factors which are completely different. This is our brief presentation about acute lymphoblastic leukemia. We tried to make it short as much as possible. Wish you understand something. Thank you.